now recognize myself for 5 minutes. Dr. Chen, in your written testimony, you mentioned our country will have a shortage of over 87,000 primary care physicians and nearly 210,000 nurses by 2037. And these shortages are not evenly distributed. They are especially acute in rural areas like the area I represent. I understand there are common challenges shared by multiple types of communities. Given this disparity that you highlighted, would it make more sense to better target our Title VII and Title VIII resources to include geographic need instead of just looking at that based on race or ethnicity, as some of the programs are currently operating?
Thank you for the question, and it is a very good question, particularly as I sit here next to the head of the Federal Office of Rural Health Policy. Rural health workforce faces significant...
Yeah, if you could speak up just a little bit.
I'm
Yeah.
sorry.
All right.
Significant and very unique challenges, and it does take intentionality in addressing rural health workforce shortages. I would say Tom Morris is probably one of the people that I work the most with at HRSA to coordinate some of our programs. However, there are ongoing workforce challenges in urban and in suburban communities. For example, out of that 87,000 primary care physician shortage that we're projecting, well, 18,000 of that is in rural communities. 69,000 is actually in non-rural communities. And so it really does require that we consider all communities and all communities facing those challenges.
I appreciate that, and you mentioned National Health Service Corps and the Nurse Corps in your opening statement, and I got one of these curious questions that comes to me when witnesses are testifying. Did you grow up in the D.C. area?
I did. I grew up in, yes.
Because one of the things I love about I call it the Northern Exposure model that the National Health Service Corps, for those who don't know, it's an old TV show where a doctor goes to Alaska because he needs to pay off his student loans, and he goes up there with a 5-year commitment. And it was a nice show, but it also shows how sometimes you go to another place and you end up staying. And that's why I was curious as to what area you had originally come from. I was thinking maybe you came to D.C. because of the National Health Service Corps, but we're glad you're here. That said, do you think we need to authorize more funding for the National Health Service Corps and the Nurse Corps in order to expand those opportunities for rural and underserved areas?
We defer funding decisions to Congress, of course. However, as I mentioned, the National Health Service Corps is able to award about 50%. The Nurse Corps is only able to award about 6% of all new applications in a year. So there is a lot of opportunity there.
Yeah, and of course, this committee only can do authorization. We can't do the actual expenditure. That goes to appropriations, but I appreciate that. Mr. Morris, love you talking about telehealth. I've always loved telehealth, and in fact, I carried the House version of the telestroke bill when it first came forward. The resource centers, the telehealth resource centers, which we are looking to reauthorize in the bills today, serve a vital role across the country, especially rural areas like my district. The University of Virginia is currently the resource center for my district and all of the Mid-Atlantic. Does HRSA distribute resources based on need, or are the allegations the same for each center?
For our telehealth network grant program, like many of our programs, it's a combination of those things. Certainly, need is a key factor in it, but we also want to make sure they have a viable work plan to move forward and that they have the personnel necessary to carry it out. So it's a combination.
Okay, I appreciate that. The University of Virginia has experienced a 24% increase in telehealth visits from their program from fiscal year 24 to fiscal year 25. As we look to extend telehealth flexibilities and coverage, do you think that we need to expand the number of centers that we have, thus reducing the geographic footprint that each center serves?
Well, thank you for the question. It's interesting. We've been focusing on telehealth in rural areas for more than 30 years, and your record goes back. I think I talked to Karen Rubens yesterday that back to the mid-'90s when you were advocating for this, and so with the pandemic, we saw the benefits of telehealth universally. And so the technology is getting less expensive each year. You can now use a personal computer. And so we're moving less from a hub and spoke model to a distributed. And so the more access points, the better. It can be in your home, it can be in the clinic. It's a continually evolving technology, but it's certainly being tailored more to the patient. So the more access points, the more access.
All right, I appreciate that. And it is And we all lost friends. I lost a dear friend in the COVID crisis. The one thing that came out of that was healthcare providers suddenly realized that telehealth was not as alien as they originally thought, and it was greatly expanded, and we should continue that.